Hello everyone, and welcome to another episode in My Spine World. Today I'll be talking about lumbar spine fusion surgery. Lumbar spine fusion surgery has been around for several decades now. In this video, I'll be talking about various techniques of lumbar interbody fusion surgery, starting from the traditional techniques to the recent advanced ones. Before we deep dive into various techniques of spinal fusion surgery, let's analyze what exactly is spinal fusion. Spinal fusion or spinal fusion surgery is a surgery to permanently connect or weld together two or more vertebrae in the spine and eliminating motion between them. So what are the conditions that actually require a spinal fusion surgery? It can be broadly categorized into degenerative, infective, trauma, or tumor. In the degenerative category, it could be because of a spinal stenosis or narrowing of the spinal canal. It could be a spondylolisthesis or instability. Now, degenerative conditions are the most common conditions that would require a spinal fusion surgery. Now, these degenerative conditions can present as either a neurogenic claudication or pain in both your legs, especially after a certain distance of walking. It could be radiculopathy or a shooting pain down your legs due to a foraminal stenosis, or it could be degenerative spinal deformity or a curvature of your spine like scoliosis or a spondylolisthesis, or it could be just back pain. It could be either discogenic or from the disc, or facetogenic, could be from the facetal joints. There are various ways where you can do a lumbar fusion surgery. The most commonly used or the traditional techniques used to be posterolateral fusion and then the lumbar interbody fusion. In this video, I'll be talking mainly about various techniques of lumbar interbody fusion. Lumbar interbody fusion means placement of an implant, could be a cage, spacer, or a structural bone graft within the intervertebral space of the lumbar vertebra after a discectomy and endplate preparation, and further stabilization with pedicle screw and rods, as shown in the picture. Lumbar interbody fusion is an effective treatment option to stabilize the painful motion segment of the spine. It provides direct or indirect decompression of the neural elements. It restores lordosis and corrects deformity. Now let's look at what are the various options that are available for a lumbar interbody fusion. Again, it can broadly be categorized into posterior, anterior, or lateral. Posterior, which used to be the more traditional techniques, includes the TLIF or the posterior lumbar interbody fusion, or a TLIF, which is a transforaminal lumbar interbody fusion, and then MI TLIF or MIS TLIF, which is a minimally invasive transforaminal lumbar interbody fusion. For anterior, you have the ALIF or the anterior lumbar interbody fusion. And for lateral approaches, you have the OLIF or the oblique lumbar interbody fusion, or ATP or anterior to psoas approach. And also we have the ALIF or XLIF, which is a lateral lumbar interbody fusion or extreme lateral interbody fusion. All the various names that I've told just now, all means it is an interbody fusion or a lumbar interbody fusion. The difference is actually the approach that you take to do the lumbar interbody fusion. So for an ALIF or anterior lumbar interbody fusion, the approach is direct anterior. Whereas for a PLIF or a TLIF, the approach is from the back or the posterior. And for XLIF or an OLIF, the approach is lateral. For XLIF, it will be extreme lateral. OLIF, you have an oblique approach. Now let's analyze each technique one by one. Let's discuss about the posterior approaches first, which mainly comprises of the PLIF as well as the TLIF. PLIF is posterior lumbar interbody fusion and TLIF is transforaminal lumbar interbody fusion. These approaches are traditional and most of the spine surgeons are more familiar with these approaches. They are frequently used with acceptable fusion rates and low complication rates. However, these are limited by your thecal sac right in the middle as well as involves nerve root retraction. It is also associated with iatrogenic injury to the paraspinal musculature during the procedure and also hence disrupting your posterior tension band. The MIS TLIF approach attempts to reduce the approach-related complications like injury to the paraspinal musculature and less disruption of the posterior tension band. This picture actually demonstrates PLIF as well as TLIF. In PLIF, you don't take out the facets on the side and hence involves a lot of neural element retraction. Whereas in TLIF, which was an evolution from the PLIF technique, the facetal joints were taken off and the approach was through the foramen and hence named the transforaminal interbody fusion. And TLIF involves less retraction of the neural elements compared to a PLIF technique. Now let's look at the anterior or lateral approaches. The advantage of an anterior approach like ALIF or a lateral approach like OLIF or the XLIF is that it avoids the spinal canal. It avoids the chorda equina and nerve roots. And also you have a bigger fusion surface and a bigger spacer can be inserted. But the downside of it is you can have an approach related either abdominal or a vascular complication, especially with an OLIF. In addition, lateral and OLIF techniques have potential risk of lumbar plexus injury, especially with an XLIF and psoas muscle injury. So this diagram in brief describes the various approaches that is used for lumbar interbody fusion. So you have the PLIF and the TLIF, which is your posterior approaches. PLIF is without taking out the facet joints and TLIF is through the transforaminal approach after taking down the facetal joints. The XLIF or the LLIF is actually right through the psoas muscle, which is a lateral approach, and by retracting the lumbar plexus. The OLIF or the oblique approach is actually between your psoas muscle here as well as the major vessels. The ALIF or the anterior lumbar interbody fusion is a direct anterior approach, which is usually done these days in a retroperitoneal manner. Now let's talk about posterior lumbar interbody fusion or PLIF. It is done as the approach says posterior. The patient will be in a prone position and the laminotomy or removal of the lamina is done, which is done medial to the facetal joints and involves retraction of the dura and the nerve root almost up to the midline to create a corridor to the disc space anteriorly, and then involves preparation of endplates as well as disc space for allowing implant or a spacer insertion. Because of the peculiarity of the approach itself, there are particular concerns surrounding especially potential nerve injury, dural tears, as well as epidural fibrosis. And this is how a PLIF cage would look like. They are small and bullet shaped. They are small because the corridor for insertion is also small, the corridor between the neural elements as well as the facetal joints, and hence you would have to put 2 bullet cages on either side. Here's a radiographic image of a 2-level PLIF or posterior lumbar interbody fusion surgery at lumbar 4, lumbar 5 and lumbar 5 sacrum 1. Here you can see the 2 small bullet cages inserted bilaterally on both levels and reinforced by pedicle screws and rods. Now let's talk about TLIF or transforaminal lumbar interbody fusion, which is an advancement from the PLIF. This is also done posterior. The patient is in the prone position. It is a direct unilateral access to the intervertebral foraminal space. There is less neural element retraction that is needed, and also there will be a larger surface area for fusion and a bigger spacer insertion is possible. So this is a pictorial representation of a transforaminal lumbar interbody fusion. So you can see the laminotomy which has been done at this level, and the facets on this side has been taken out. This is a facet joint which is preserved on the opposite side, and the cage going in. Because of the more lateral approach of insertion of the cage, these cages used to be what we call as a banana-shaped cage, so that it can be inserted from the side and it can be directed right up to the middle of the disc space. As you can see, because of the approach, there will be less retraction of the neural elements. And here's another pictorial representation of TLIF. Here you can see The approach is actually between or lateral to the neural elements here. So it will be between your exiting nerve root as well as the traversing nerve root. And here is a radiographic image of a lumbar 4, lumbar 5 transforaminal lumbar interbody fusion reinforced by pedicle screws and rods. The diagram in the middle represents stepwise approach for a TLIF. Step 1 would be removing the lamina. Step 2 would be removing the inferior articular facet. And step 3 would be removing the tip of the superior articular facet and hence creating the corridor to the disc space laterally. Here's how a TLIF cage would look like. It is bigger than a PLIF cage. It is more curved or more banana shaped. Because there is bigger surface area for fusion and the cage can reach almost to the midline, bilateral cage insertion is not necessary. Traditional TLIF surgeries were performed open, which involved more muscle dissection, and hence posterior tension band was lost. The MIS TLIF was performed via a mini open approach with smaller incision sizes, which involved less muscle dissection, less blood loss. Now let's talk about anterior approaches or anterior lumbar interbody fusion. Anterior lumbar interbody fusion or ALIF is done in a supine position and uses anterior retroperitoneal approach. It gives adequate access to the entire ventral surface of the exposed disc, allowing a comprehensive discectomy and a direct implant insertion. It uses a midline or a paramedian approach at all levels, or a mini phenolphthine at L5S1 level with a retroperitoneal corridor, and involves vascular mobilization. The advantage of ALIF is that you can insert a bigger spacer and it gives you a substantial correction for deformity. The ALIF approach is best suited for lumbar 4, lumbar 5 levels and lumbar 5 sacrum 1 levels. Primarily the lumbar 5 sacrum 1 due to the vascular anatomy. As you can see, the approach would be between your right and the left common iliac vessels for L5S1. And also the picture depicts of how a comprehensive discectomy can be done at this particular level, allowing for a bigger cage insertion and also allowing for a bigger correction of the deformity. Here's a picture of some of the ALIF cages that can be used. So it can be a standalone cage with screws going into the vertebra above and below, or even blades is going into the vertebra above and below. Because a comprehensive discectomy can be done, the cage size would be bigger and can also dial in various amounts of lordosis, allowing for better deformity correction. Here's an example of two-level ALIF performed at lumbar 4, lumbar 5 and lumbar 5 sacrum 1 using standalone cages and screws. You can see how a big cage can be inserted right from the front with screws going into the vertebra above and below. Now let's talk about lateral approach, which is the extreme lateral interbody fusion or a lateral lumbar interbody fusion. This involves accessing the disc space via a lateral retroperitoneal transpsoas corridor. So it's a lateral approach through a transpsoas corridor into the disc space. These are suitable for conditions that require lumbar interbody fusion and access to the interbody disc space from T12L1 to L4L5 disc space. These are not suitable for L5S1 level due to the location of the iliac crest that obstructs the axis. Since this approach uses a transpsoas corridor, at lower levels of the lumbar spine, the lumbar plexus courses more anteriorly and the iliac vessels course more laterally. It increases the risk of injury to the nerves via a lateral approach. XLIF allows for an aggressive deformity correction with high fusion rates and comprehensive disc space clearance, but also comes with potential risk of injuring lumbar plexus, which are the nerves in the psoas muscle, injuring the psoas muscle itself, potential bowel injury, particularly at the L4-L5 level. There is also a potential for vascular injury, and if it occurs, it might be difficult to control because the patient is in a lateral position. Here's a picture of an XLIF cage on your left, as well as a radiographic image of a 2-level XLIF that is done at 3, 4 and 4, 5 levels. Here you can see the size of the cage which can be inserted, which actually stretches across the whole of the disc space. This is due to the comprehensive disc preparation that can be done through a lateral approach, and hence a bigger cage which is shown in the picture can be inserted, allowing for a greater fusion surface as well as a greater deformity correction. Now let's examine the oblique approach, or the oblique lumbar interbody fusion, or the ATP approach, or anterior to psoas approach. It is also lateral, but unlike XLIF, it goes anterior to the psoas muscle. Here the corridor between the psoas as well as a major vessel is utilized. As I said before, it does not dissect or traverse the psoas muscle, and hence injury to the lumbar plexus is avoided. Patient is positioned laterally, either left or right side up, depending on the surgeon's preference and ease of access, but usually done through the left. An OLIF allows for aggressive deformity correction like an XLIF, high fusion rates with comprehensive disc space clearance. As you can see in the picture, OLIF takes the corridor between the psoas muscle as well as the major vessel. Hence, a lumbar plexus injury which is inside your psoas muscle is unlikely, as the dissection is performed anterior to the psoas. However, potential risks include sympathetic dysfunction as well as a vascular injury. Here's a picture of an OLIF cage along with a radiographic image of an OLIF surgery is being done at lumbar 4, lumbar 5 level. The latest in the fusion techniques for a lumbar interbody fusion is an endolif. It is actually a fusion or interbody fusion that is done via an endoscopic technique, usually done via a transforaminal approach, but you have a very small incision and hence lesser blood loss, very less pain, and also an early discharge, usually one day after the surgery, or even in some centers on the same day of the surgery itself. However, it involves a bigger learning curve and various challenges involved in an endoscopic surgery, like longer operative times. Here we come to the end of the presentation. Hope you found this video useful, and don't forget to subscribe and visit My Spine World. Thank you again, stay safe, and see you again with another episode in My Spine World.